Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity. Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and very nice to see all of you today. We have very big gathering today, and we are all here to learn and to be able to improve our patients' outcome. We are here to improve our vulnerable pediatric critical care patients, to improve the standard of care in our clinical practice, because this is very, very pivotal, and this is the reason that we structured and organized this international online pediatric critical care fellowship. It's 1 year fellowship structured as 3 modules, 16 weeks each. And the major aim of this fellowship is to help our kids to improve their outcome. And as you may know, that we have over 180 international fellows in this fellowship program from more than 30 countries. We are very proud of that. And because we are all about high quality education and diversity and equity, we are structuring very important webinar today, trying to help you to master how to use vasopressors and inotropes in the PICU. We have a panel of expertise from all over the world. We have Dr. Rihab Ragab from United Kingdom, Dr. Ali Mustafa Ali from United States, Dr. Stephanie from United States, and Dr. Turki Al-Atibi from Saudi Arabia. Here is our brief agenda today. So please try to be patient, stay with us for this 1 hour of high quality education, and you're going to receive certificate of attendance, and you're going to be able to master using vasopressors and inotropes to your pediatric ICU patients. So after I finish this very brief introduction, Dr. Turki Al-Atibi is going to introduce Dr. Ali and Dr. Stephanie, who is going to give you a very nice discussion and dialogue about this subject of vasopressors and inotropes. Then Dr. Rihab Ragab will give you some case-based discussion, how to use and to apply this knowledge that will be discussed by Dr. Ali and Dr. Stephanie in your clinical practice. Then Dr. Turki Al-Atibi is going to moderate the discussion and give us the closing remarks. So 2 great speakers today. Dr. Ali Mustafa Ali is a pediatric critical care fellow at University of Texas Southwestern Children Medical Center at Dallas, Texas, and Dr. Stephanie is attending. She's assistant professor of pediatric critical care medicine at the same university. Without further ado, I will stop by here and let Dr. Turki Al-Atibi to introduce the speaker and to moderate the session.
Thank you, Prof. Amr. Hi, everybody. Welcome to our World Institute Critical Care and Emergency, to our webinar. Every now and then, every month, we invite the speaker in need of subject that we are seeing every day, and we need to also to learn from our patient every day. So the theme of our webinar today, it is about mastering vasopressor and inotropes in PICU. And the first session will be led by Dr. Stephanie and Dr. Ali, who just Dr. Amr, Professor Amr, present about it. I will give you some information about our 2 speakers. Dr. Stephanie did her medical school in Vanderbilt University School, then she did the pediatrics program, followed by that doing her fellowship in pediatric critical care medicine in University of Texas Southwestern Children's Hospital Center, and become faculty, and currently she's associated professor there. Note that Also, she is Associated Program Director in Pediatric Residency Program. So welcome, Dr. Stephanie. Dr. Ali, he did the medical school in Alexandria University in Egypt, and moved to USA and start to work in clinical research, and with many interesting in surgical ICU, trauma, bear, in Cook County Hospital in Chicago. Then he did his residency in pediatric program in Texas Tech University, and to get the American Board in Pediatrics. Currently, he's a senior fellow in pediatric critical care medicine at University of Texas Southwestern Children's Hospital. So welcome of you, and they will talk about the dialogue of using or dialogue of vasopressin and inotropes in the ICU. So welcome both of you, and you can start it.
Yep. Can you guys hear me?
Yes.
Yeah. Thank you so much for this introduction. Thank you, Wickham, for having us today. Thank you, Dr. Armour and Dr. Turkey, for our introduction. Have the pleasure of doing this lecture with Dr. Stephanie Xu, my attending and mentor. So today we're going to talk about vasopressors in pediatric acute critical illness, and we specifically said pediatric acute critical illness. We did not talk about pediatric ICU because we know that some of those patients vary in their location of their acute presentation, and not all of the hospitals are equipped to have pediatric ICUs in them. But we're going to talk about general concepts about vasopressors. We're predominantly going to talk about the mechanism of actions and describe the agents that we have and how many do we have in our arsenal when talking about vasoactives or vasopressors. And then when are they clinically indicated? When can we use double therapies for them? And of course, identify specific circumstances where we can use adjuvant therapies to help augment our pressors need. And then eventually define vasoplegia, refractory shock. So with Dr. Xu, we're going to be presenting her with a case, and I'll engage how Dr. Xu is thinking about this case. So we're going to present with a 3-year-old Dr. Xu. Very common for us in the ICU, we see them. It's a 3-year-old coming in with 3 days of fever, I think decreased activity, poor intake. The mom brought him in the emergency room saying, kid is just difficult to awaken them to daycare this morning. They assessed them in the ED. The patient has been tachycardic to 130s, hypotensive with MAPS of 45, tachypnic. Patient is febrile, having some desaturations on 85 and room air. When they examine the patient seemed to be altered in the mental status. They have delayed capillary fill, cold extremities, mottled skin, and has not been producing much urine output in the past 24 hours. So they did some labs and they looked at the lactate has been elevated. They see that there's inflammatory markers are also high between the CRP and procalcitonin. Patients seem to have hyaline gap metabolic acidosis. There's a kidney affection with elevated BUN and creatinine, transaminitis, and leukocytosis. The ED gave him a rapid flow resuscitation with LR, about 40 mLs per kilogram in aliquots, and started early broad spectrum antibiotics. They were unable to get good IVs, but a seasoned nurse came in and tried to put a 22 and 24 gauge in this patient. And then they called you for admission in the hospital. They said the patient is already running their third bolus. We have him on high flow nasal cannula to have him saturating, but the patient continues to be tachycardic, hypotensive when they present it to you in the ICU. And I was wondering, Doc, how are you thinking of this patient? How does that impact your choice of pressors when you start seeing them, and how do they work in your mind?
Yeah. So I think first off, we recognize this is a really sick kid, right? So initial triage, sick, not sick, he's sick. And several things that you have mentioned already make me worried about shock. So shock being he has inadequate oxygen delivery for their oxygen demand. So we're thinking DO2 and VO2 here. So in a shock state or low tissue or inadequate tissue oxygen delivery, you're worried about already seeing signs of organ injury, right? So you have brain hypoperfusion. You're saying that he's altered, he's unable to wake up normally. So I'm worried that he's quite sleepy. He has evidence of kidney or renal hypoperfusion. He's not making good urine. He has increased BUN and creatinine. And then you have some transaminitis that's probably suggestive of some early liver injury or liver hypoxia as well. And then obviously lactate as well. You're telling me it's some high number. So lactate being an indicator of I've switched from aerobic to anaerobic metabolism. So a good marker of I don't have enough oxygen going out to the tissues that need it. I think you're leading me down right towards an infectious etiology. You're saying that they're febrile. His temp is 39.8. He has high inflammatory markers. And he has a leukocytosis. So you're suggesting this kid is in shock, likely due to an infection. So now we've categorized him into septic shock. Does that answer your question?
Yeah, so it seems like you looked at the patient clinically, you see that the patient is still in uncompensated septic shock. They already gave him a fluid, either giving the third bolus, and now you're starting to say septic shock. So what are the pressors that I can think of as a first line when using this patient?
Yeah, that's a great point. So you mentioned kind of our fluid or volume resuscitation of the patient. Usually volume, yes, is your first line. I see they're hypotensive. I need to increase my intravascular volume, but he's hit that critical mark of 60 per kilo. So between the ER and us, we've gotten a total of 60 per kilo. And so I'm thinking what we call fluid refractory shock. So continuing to give more volume probably isn't going to do much more. I would expect by now that's going to help primarily their blood pressure. I would have seen a response. And so, yeah, now we're thinking into the vasoactive support to further augment their mean arterial pressure. And so this image is nice. So we think about, I think you want to jump right into the vasoactives, but let's think about where they're working and therefore which ones we can use. And so our primary receptors that we think about are their alpha-1 and our beta-1 and beta-2 receptors. And so these are adrenergic receptors. Alpha-1 is going to be primarily vasoconstriction. And so you are going to get really good, pretty quick response at increasing your SVR. And this downstream effect of that, you're going to see nicely, hopefully, increase in your mean arterial pressure. On the other end, we see beta-1 and beta-2, which work slightly differently. So beta-1 is going to give me true inotropy. So you see that word inotropic response. Inotropy meaning increased contractility or increased squeeze of the heart. So I think of that in my cardiac kids where maybe the squeeze or the myocardium is not pumping quite as well, and that's leading to this shock state. And then beta-2 is sort of tricky. It's both vascular and smooth muscle relaxation. So you can sometimes see a slight drop in your mean arterial pressure. So have to think wisely about how we use them. And so I guess we can just go in order from left to right. So you see kind of these are laid out based on where they lie on the spectrum of alpha to beta. Norepinephrine you see on the left, it's primarily alpha-1. So norepi is nice, would be nice in this patient, and that I should get nice vasoconstriction, a nice increase in my SVR, and subsequently a good, hopefully, response in my mean arterial pressure. So we saw the blood pressure was low, a map of, I think it was 40, 42. And so hopefully this will kind of give me a nice boost as soon as I start it. And then you see in the middle, epi and dopa. These are probably a little bit more common when we think about shock, but kind of work in a tricky way. You have to think about them. And so epi, you see kind of two areas, low dose and high dose. So at lower dose, meaning less than 0.1 mics per kilo per minute, is going to cause more beta-1, beta-2 response. So I mentioned a little bit earlier, I think about contractility or heart squeeze. When I think of beta response, so epi at a low dose, so less than 0.1 mics per kilo per minute, it's really going to help me more in the function of the heart, squeezing of the heart. And it's really not going to give me a nice bump in my mean arterial pressure until I get to the higher dose, so greater than 0.1 mics per kilo per minute. Dopa is somewhat similar. We fondly call dopamine dirty dopa, in that it's not as precise in its receptor targets. So dopa is the precursor to the synthesis of both epi and norepi. And so you give dopa, you're going to get this kind of shotgun response. You're going to get some alpha, you're going to get some beta, and beta 1 and some beta 2. And similar to epi, you're going to get a different response at different doses. And so dopa, in the shock dosing, we really think about 5 mics per kilo per minute or higher. So low dose being kind of the 5 to 10-ish mics per kilo per minute, similar to epi. You're going to get really more beta than alpha. So again, more inotropy or squeeze of the heart, and less vasoconstriction or vasopressor action. Really, until you get greater than 10 mics per kilo per minute, then you're going to get more of the alpha. So more of the increase in your systemic vascular resistance, increase in your mean arterial pressure. So those two can be nice drugs in that you can use one drug to get to different effects depending on what dose that you're using.
Yeah, so that makes sense. So it seems like you're saying that there's alpha and beta receptors. There's ones on the either very end of the spectrum, where it's norepinephrine predominantly alpha and dobutamine predominantly beta. We have epinephrine and dopamine, which varies based on the doses of which one interact with. And when you're trying to pick specifically which one you want to start in these patients, you have to factor in, is it just the vasopressors that you want, or need an extra squeeze from this epinephrine that you're trying to add on, where that sits. And it seems like we at times in the ICU also see phenylephrine, but I predominantly only see transiently from those spinal surgery patients who stay in the anesthesia room, and we just use it in the OR, but we don't really inherit using that drip predominantly in the ICU moving forward from there, and predominantly switch them to norepinephrine. Does that summary kind of make sense, Dr. Sir?
Yeah, that's a perfect way to think about this spectrum. Phenylephrine, yeah, we really only see in a very select population, typically more our spinal patients. And you saw on the prior slide, it's all the way to the left, meaning it's an incredibly potent alpha-1 constrictor. And so you have to be cautious, because you can see kind of detrimental effects of too much phenylephrine, too much alpha. Primarily, we see that in renal ischemia. And so kind of the use has kind of shifted more toward more epi and epi than phenylephrine, which is incredibly potent alpha-1.
Yeah, so that makes sense. So we want to predominantly be also aware of the drugs that we have in our arsenal, but how far their side effects can go. And I think this table is a very good table that rounds up everything and sums it in, where it comes in the doses, but not just that, just the side effects and how the effect of the dose per the cardiac output, heart rate, MAPS, and SVR. And one thing I found interesting here, Dr. Shrew, is if you look at epinephrine, for example, you see one of their side effects like hyperglycemia and lactic acidosis, which can be counterproductive in septic shock when you're giving them those pressors, but you can increase their lactic acidosis by just using the epinephrine. So how do you think of all of these drugs and side effects and their different doses is summarized in this table? When you come up for this patient, for example, which one would you use first?
Yeah, so I think colloquially, we probably have been trained and think about, epi when I think about a kid in shock. But really, I think more of norepi, because I think of the patient that I'm seeing in front of me. Typically, what we're trying, the primary vital sign, right, that we're all watching is probably their blood pressure. And so, as we mentioned earlier, really, you're not going to get much change in your SVR and much change in your mean arterial pressure at really lower doses of norepi, whereas at lower doses, right at initiation of norepi, you will get more of that effect. So typically, I think of norepi, especially in septic shock, as my first line agent. I start to think about epi if I have an inkling or I have a suspicion, or the patient has a known cardiac history, so cardiac dysfunction, whether that's myocarditis, whether that's an intrinsic known cardiac dysfunction, or heart failure of some sort. I think more so on the low dose epi infusions. Again, we're in the environment in which we practice. You and I, Dr. Ali, we have multiple agents at our disposal. And so in those settings, we have the luxury of saying, you know, I'm going to reserve DOPA, I'm going to reserve dobutamine. Really, if I have to think further down the line, but norepi and epi is primarily where we are. I see a couple others on this chart. Did you want us to go through those, Dr. Ali, specifically vasopressin and milrinone? Would that be helpful to also discuss?
Yeah. So it seems like you're saying for this study, you want to start with norepinephrine, you want to increase the dose, and you're starting to think of a second agent to add with this patient. You're maybe thinking of epinephrine, maybe you're thinking of vasopressin. Why would you add vasopressin? When would you start thinking of adding the second agent? And is there a number that you're thinking of? Yeah.
Yeah, sorry, I skipped over that. You're absolutely right. So norepi is usually what I think first line septic shock. I'm thinking kind of starting dose 0.2, 0.4 in a kid, you know, I've gotten some volume resuscitation. I see some response. I just need a little bit more help. And a kid who I've given 60 per kilo and I'm still just low blood pressures, I haven't made much of a difference. I'm seeing accumulated organ injury. I may start a bit higher and be more aggressive up front, 0.05. 0.06 or so. I typically will walk that up to about the 0.1 mics per kilo per minute range. And by that point, I'm usually thinking about a second agent, typically epinephrine. Depending on kind of their response to norepi, again, epi starting around the same dose, 0.02, 0.04, if I just need a little bit of squeeze, a little bit of help in the cardiac contractility bucket. Versus I'm thinking this kid is incredibly sick. I'm down up to 0.08, 0.1 of norepi. I haven't made much of a dent. Then I'd probably start on the higher end again, 0.05, 0.07 maybe, mics per kilo per minute of epi. If I'm truly having refractory shock, I'm thinking now my norepi's at 0.1, my epi's at 0.1. I'm still having issues with hypotension, with poor oxygen delivery and inadequate response. You're kind of now you're into the style, right, of how you practice. Some of us will kind of push the upper limit of both these doses to 0.12, 0.15 mics per kilo per minute, depending on the size and the age of the patient, and are closer to adult-sized patients. So whether that's in true size kilos versus age, chronologic age, sometimes we'll push it to 0.2. So we're thinking kind of mid-late adolescents, 15-year-olds and higher, and where kids closer to 60, 70 per kilo, where they can probably handle a bit more higher dosing. If despite all of that, I'm still kind of in the bucket, still not quite meeting my goals, that's when we think about, okay, how can vaso maybe be an adjunct therapy to us, specifically because vasopressin works on, we can see in this chart, completely different receptors. Vaso is not acting on the adrenergic receptors. And so can I get a different mechanism to target a different pathway to also augment vasoconstriction? And so vaso works with the V1A receptor, and it potentiates the vasoconstrictor effect of the catecholamines because it's going through a completely different pathway. And so in kids that were on 2 agents that I'm not seeing like adequate response, we'll start some vaso. And surprisingly, some of these kids will have a profound response, and then you can start working down on your epi and norepi doses from here. The milrinone is kind of in that cardiac category as well. So the kids who have, now I'm thinking more cardiac dysfunction kids, cardiomyopathy, myocarditis, because milrinone, again, different pathway, it's a phosphodiesterase 3 inhibitor. It's really going to increase your intracellular calcium through a different pathway, and it results in inotropy and lusitropy. So the primary effect I'm looking for here is relaxation of the heart, lusitropy. And so I think of that in a stiff heart or sick heart that I'm not able to feel because it's too stiff. And so milrinone will help relax the heart a little bit and let it fill so that I can then increase my cardiac output in that way.
Oh, that makes sense. So you're trying to tell me that I have to have in mind, I think there's an echo. I think there's an echo from me. So I think you're trying to tell me there's two ways when we're looking at this. There's that patient that comes in septic shock, but you have to also keep in mind if there's a patient that has a cardiogenic shock. And if they're having a septic shock and you're starting your first agent, norepinephrine or epinephrine, doesn't really matter which one we start, but if we do start with norepinephrine to get more vasoconstriction, when we reach a specific dose, we started at 0.02, we reach a 0.05, 0.1, we're starting to add a double agent. We start a lower dose of epinephrine to add more squeeze to it. And then once we are higher dose on both of them while we're titrating them, and we have more of the higher dose effect of epinephrine, let's start thinking of a third agent that has a different way of mechanism as vasopressin. While we do those, we have to be aware of their side effects, right? Which is, well, if I keep going up on the epinephrine, I'm going to increase the metabolic demand of the heart itself. I'm going to increase more lactic acidosis and hyperglycemia while I do this. While I'm increasing my norepinephrine, at times I'm risking the gut and the renal perfusion at those higher doses. But I have to play a fine balance. When we compare those, for example, for dopamine, we saw that dopamine has more like arrhythmogenic and higher motility than norepinephrine and epinephrine. But eventually, if this is the resource you have, you can use them. And since we mentioned Milernum, now if we have the same patient that we talked about, but we're adding more of a slight twist to it, which seems to be, does this patient have low heart rate? So it's the same patient that came in, but their heart rate is sitting in the hundreds. They're hypotensive. Their saturation is still low. They're also altered. They have almost the same presentation, but this is a 4-monther, right? And we gave them the same amount of bolus, but for some reason, when we gave them more bolus, the patient started to require more and more oxygen requirement. Their clinical exams seemed to be more tachypnic, more pulmonary congestion. They were restricted in the emergency room, and they were able to get an X-ray of the chest later on. They saw there was a cardiomegaly, and they swabbed the patient, ended up having adenovirus or rhinoenterovirus. And how would that make your perception of this patient different from your fluid resuscitation, but also from your vasoactive support requirements?
Yeah, so this child, as you pointed out, is different in a couple but critical ways. So he is he's an inadequate tachycardic for the degree of decreased cardiac output that he has. So that one is concerning. And then really as the course pans out, with fluid resuscitation, you're mentioning or you're describing fluid overload, really with low, starting at less than 40 per kilo, it sounds like, was already starting to show me signs of fluid overload with the what you're suggesting, the pulmonary edema or pulmonary overcirculation, and liver. I think you mentioned that his liver was down, perhaps thinking of heart failure, heart dysfunction with backflow downstream from the heart, cardiomegaly, and then the positive viral panel. Both of these things together are already are adding to this picture of, does this child have cardiac dysfunction, likely from an acute viral source? And that usually makes us think about some sort of viral myocarditis. And so in this kid, yes, we think about them differently in that beyond just a shock state, they have true cardiac dysfunction. And so if you think all the way back to that initial slide, you're thinking probably more on the cardiac support, more on the beta side initially, rather than primarily focusing on alpha. So for this kid, I probably would start them, rather than reaching for norepi first, probably would start with epi, and see if I can really augment the contractility, augment the squeeze of the heart and help it empty. Because what I'm seeing, or what I'm suspicious of, is that, yes, I'm filling the heart, but the heart doesn't have that function, that squeeze, to then subsequently push all of that volume outward to the rest of the systemic circulation. In this slide too, kind of thinking back to dobutamine and dopa that are hit higher on this synthetic catecholamine pathway. And so if you start with dobutamine, you're going to nicely get both that alpha and that beta effect kind of downstream from initiation of that as your first line vasoactive. And then we touched on milrinone previously. So can you help with relaxation of a stiff heart or a sick heart as an adjunct to the other vasoactives that we've discussed? I think one thing that you had also suggested was thinking of side effects, which I think is important, and particularly with milrinone, right? We think about with relaxation of the heart, you also get some relaxation of your systemic vasculature too. And so you think about the phrase we usually say in the unit is, do you have enough blood pressure to start milrinone? So you need to start with a little bit higher blood pressure before initiation of milrinone, because you do anticipate a slight drop in your mean arterial pressure with initiation and relaxation and vasodilation that you see with initiation of milrinone.
So it seems like I would still start my epinephrine. I probably would avoid starting norepi in these kids. It seems like I would be more refrained from giving them more volume. I would start thinking early of milrinone, knowing that it will help with the relaxation of the heart, coronary perfusion, and would usually start at like 0.25 mics per kg per minute while I start my epinephrine to help more with the ventricular support and cardiac output. Now, I know that you were saying that is going to decrease your SVR, your systemic vascular resistance, and probably your renal perfusion. And happens usually 24 hours-ish, or at least 12 hours after initiation of milrinone. So we have to keep that in the back of our mind. If the pressures are too low after 12 hours, that's probably the milrinone effect, and that's renal affection. But you also mentioned that, what about as an adjunct therapies, right? So special concentration, other medications that we can use to augment. And I've seen you specifically when I worked with you reach out more for steroids than you would be more reserved later on. You'd actually early on start these kids on hydrocortisone. So where's the perspective of adding steroids as an adjunct therapies when it's not a pressor per se?
Yeah, so we think of a child who we're providing with stimulating their adrenergic receptors, and you're on quite a bit. So you're on norepi of 0.12, epi of 0.1, and I'm still kind of not getting the effect that I am hoping for. You start to wonder, does this child have some element of adrenal insufficiency, whether that's acquired, so just temporary in this really critical illness state where you have a secondary organ injury, versus intrinsic, though less likely unless it's a kind of brand new presentation as a young infant. We've seen, you and I, both in the unit, kids who are on dual vasoactive infusions. We're reaching for a third agent with vasopressin, and we say, logically, this previously healthy child who's here with septic shock, you would assume had totally functioning adrenals prior to this acute illness. In this setting, I think they're acting like an adrenally insufficient patient. So why don't we go ahead and try to stimulate with stress hydrocortisone in a similar way that we would think about a child with adrenal insufficiency. And we've seen in those kids, they can have a response. I can't quite explain it, perhaps just truly critical illness simulating adrenal insufficiency. You give them a dose of stress hydrocort. In our unit, we use 100 milligrams per meter squared times 1. That's just a one-time stress dose of hydrocortisone. And what you may find, it's gonna be somewhat of a delayed response, but in the next kind of 4 to 6 to 8 hours, you start to notice, hey, I am now no longer chasing this blood pressure. I'm not having to titrate or increase my vasoactives as much as I was before. And actually, I'm starting to be able to peel off some of these vasoactive infusions. In those kids that I think I'm having a substantial response to the hydrocortisone, stress hydrocortisone dose, we consider continuing that dose at 25 milligrams per meter squared every 6 hours for a couple of days, just to perpetuate that response. You and I have both seen incredibly sick kids who were adding on therapies too, where we've given them a stress dose of hydrocort, and we've seen that pretty profound response in the next several hours. So I've had a really good track record with using hydrocort specifically in our septic shock patients.
So it seems like you have a septic shock kit, you're already on double pressors. We know there's no max dose for those pressors. However, whether it's a chronically sick kid or previously healthy kid, you'd want to reach out to those steroids early. You'd reach out to those steroids in those previously healthy kid because you see delayed to an extent benefits of the steroids, whether it's going to increase the sensitivity of your pressors on your vasoactives, reduce the inflammation happening in the system, curb down the hyperimmune response in the septic shock patients, maybe even inhibit the nitric oxide and decrease those inflammatory cytokines traveling around. But if those kids are also chronically sick kids and we know they're adrenally insufficient, then we probably will want to give them those earlier on. And just for the sake of time, we know that there are even more in our arsenal from adjuvant therapies. We know at times reach to methylene blue or angiotensin 2, which seems like these two are more of a Hail Mary. Like eventually you have all of this and we're not sure how effective they are, and they're more studied in cardiac kids post-operatively or on cardiopulmonary bypass, where methylene blue really attacks those nitric oxide radicals and help more of calcium contraction, when angiotensin 2 more react as a vasoconstrictor, but also affect the lungs and the pulmonary perfusion, the renal perfusion, but they have not been studied effectively. It depends on your resources. And the rest of them, predominantly the insulin or the intralipids, there are specific vasopressors that we want to use in certain conditions, right? Like if the patient coming in with calcium channel blockers overdose or beta blockers overdose, want to give them the high dose insulin because it can antagonize the effect of it, helps more cyclic AMP be in there and helps your cardiac contraction, and a higher dose of insulin with glucose in it. When the intralipids, and we talked about it, is usually encodes that when you have them in lidocaine toxicity predominantly is my understanding, and that's where the problem sinks in. Is that a correct way of describing those adjuvant therapies, Dr. Shri?
Yeah, I would just correct just one statement that these are not vasopressors. I think probably just a misspeak, but just to clarify, high-dose insulin, intralipids, these other adjunct therapies are not considered in the category of vasopressors. These are adjunct therapies. Angiotensin 2, methylene blue, and 5-maybe-12 are more so, like you're saying, the radical scavengers, and anything really you can do to counteract refractory vasoplegia. So reduce the other chemicals that may be causing vasodilation. So take away the vasodilator trigger and hopefully kind of further improve your vasoconstriction effect. And then the insulin and then the lipids primarily are very specific for certain toxic ingestion. So just caution you against saying my patient is refractory vasoplegia, I'm going to across the board start insulin or lipid infusions. Those are specific to certain toxicities. So calcium channel blockers, beta blockers, you think about insulin infusion. And then for lidocaine, like you're saying, and certain calcium channel blockers, you can think about lipid infusions. So just want to be cautious and thoughtful about which scenarios to choose those for.
That makes sense. And then one thing you always taught me as we're wrapping up this is always think of your end in mind. Is this kid can make it with the resources that I have? Do I have to start thinking, well, this kid needs ECMO, whether it's VA ECMO support? Should I start transfer them early? Are they stable enough for us to transfer them while we start those pressors and we escalate, and how fast we're escalating on those pressors? And when we start considering them in resource constrained settings, we have found that whether it's the central use or peripheral use of pressors, you have to do with whatever you have in your access to deliver those to salvage the patient. And once you perked up their blood vessels, you can attempt for a central line if you only have a peripheral line. And it seems that we can use it until we see side effects from it. And then overall, you can still use dopamine if that's the only one you use, but there's no real evidence to tell you epinephrine versus norepinephrine that we use norepinephrine early on for those kids that you need a vasopressor effect on the vasoactive support, and epinephrine if you need more of a cardiac support, unless you're going to go higher in the dose. What's any final remark, Dr. Shu, before we end the slide?
No, thank you guys for having me. I think I was talking to Dr. Ali beforehand, the two things over the course of my training that's kind of shifted my understanding of my use of vasoactives is kind of this shift from I used to always think epi first line and now realize more so norepi is probably going to get me faster the effect that I am intending with SVR, mean arterial pressure, and oxygen delivery and circulation. And then two, as I mentioned, considering high dose steroids or stress dose steroids with hydrocort, even in those kids that you think I don't really understand why or how it could be working. I have seen kids kind of walk back from pretty profound vasoplegia, pretty profound septic shock, and be able to start to wean down on a lot of things in a way that I wouldn't have expected prior to my experience in my training. But thank you guys so much for having me. Dr. Ali, and I will stay.
Yeah.
Thank you very much.
Thank you so much, Dr.
Dr.
Shu.
Stephanie and Dr. Ali, for nice this presentation and dialogue, interesting cases. So the question will be after the second session. So now Dr. Rehab Ragab will talk about case-based discussion. Dr. Rehab, she is a former consultant of pediatrics in Kingdom of Saudi Arabia, and now she's a clinical fellow of pediatric critical care at St. George University Hospital in London, UK. So welcome, Dr. Rehab, and the floor is for you. You are mute.
So can you see my screen, Dr. Ataibi?
Yes, we can.
You can see the vasopressin.
Yes, very clear.
Okay, thank you. So, hello everyone. It's a pleasure being with all of you today. Today I'm going to discuss the vasopressin as one of the vasopressors, which is, I believe it's underappreciated in the pediatric critical care settings. And I'm going to start with this case-based discussion. It's a full-term neonate born at 38 weeks, body weight 3.2 kilos, delivered by emergency cesarean section because of meconium-stained amniotic fluid. At the second hour of life, the baby is noted to have severe respiratory distress. And this is his clinical assessment. His normothermic, heart rate 176, respiratory rate 78, his tachypnic, blood pressure is low, 52/30 with a mean of 35. Saturation is very low, 60% despite of 100% oxygen, and he has a high pre and post ductal gradient of 20%, so his saturation at the right hand was 80%, while his oxygen saturation at foot was 60%. He's centrally cyanosed, and he has severe subcostal and intercostal retractions, tachypnea, grunting, and bilateral coarse crepitations. He has weak pulses, prolonged capillary refill 4 seconds with loud single second heart sound. He's irritable, and he has normal abdominal examination, and he has cold extremities, and his skin is dusky, cyanotic with no rashes. So management so far, he was intubated and ventilated using the high frequency ventilator, and nitric oxide was started as well. And however, his saturation is still low, 70%, despite of 100% oxygen and nitric and the mechanical ventilation. Noradrenaline was started as well for the signs of shock and hypoperfusion at 0.1 mic per kilo per minute. However, his blood pressure remained low, 60/30, with a mean of 35. And this is his post-intubation chest X-ray, which shows a pre-hilar opacities, hyperinflated lungs, and the heart size is normal. Echo was done, which showed a suprasystemic pulmonary artery pressure, a right to left shunt across the patent ductus arteriosus and the patent foramen ovale, structurally normal heart, and findings are consistent with persistent pulmonary hypertension of the newborn. So this is our problem list. We have a persistent pulmonary hypertension of the newborn. We have a right to left shunt across the PDA and PFO, and we have a refractory hypoxia despite the nitric, the oscillator, and the FiO2 of 100%. We have systemic hypotension despite of noradrenaline infusion, signs of shock, and poor perfusion. What is our concern if we try to correct shock and improve perfusion by further going up with the noradrenaline dose? The noradrenaline is going to do a vasoconstriction on both sides, the systemic side and the pulmonary side, worsening the right to left shunt and worsening the cyanosis and hypoxia. So what is our treatment strategy for this situation? We need to maintain adequate systemic blood pressure while decreasing the pulmonary vascular resistance. So we need another vasopressor which go up with the systemic blood pressure while doesn't touch the pulmonary vascular blood vessels. And we need to reverse the shunt to make it left to right in order to push the blood flow into the lung and to improve the oxygenation. So why vasopressin was considered at this situation? Because vasopressin will work only on the systemic side by the V1 receptors. So it will go up with the systemic vascular resistance without increasing the pulmonary vascular resistance, and sometimes it might cause mild pulmonary vasodilatation and some nitric oxide release. It also avoids the patient the side effects of high doses of catecholamines. So by doing that, it's going to restore the systemic to pulmonary pressure gradient. So if the systemic vascular resistance went high and the pulmonary vascular resistance is not going high as well, so the blood will be pushed from the systemic side to the pulmonary side, reversing the shunt. Unlike the noradrenaline, which cannot do that because it's doing vasoconstriction on both sides. How to use it? We can use it by continuous IV infusion via a central line, and in emergency situation, we can use it by a peripheral cannula. And this is the start dose, which has a maximum dose of 0.01 mic per kilo per minute, and needs very strict monitoring because of the risk of ischemia and hyponatremia. So side effects, hyponatremia because of antidiuretic effect, and ischemia, especially to the gut and to the skin, which has a necrotizing enterocolitis-like clinical picture. How we monitor by measuring systemic blood pressure, and it is preferred to be invasive one by an arterial line, and by clinical perfusion parameters like capillary refill time, urine output, and lactate. Serum sodium should be monitored as well, and continuous pre and post ductal sat. So we measure the saturation at the right hand and at the foot in order to monitor the difference. And our target for this difference is to go down. We monitor for gut ischemia as well, clinically by lactate and by imaging. This is the expected hospital course for this case after starting vasopressin. So after 24 hours, we have a heart rate of 160, blood pressure improving to 70/40, MAP of 50, saturation improved to 88 to 92, and we could be able to go down with the FiO2 to 70% with the high flow and the nitric. The pre and post ductal saturation gradient decreased, so the right hand now is 90% and the foot is 88, with a difference of only 2%, which means that the shunt was reversed across the BTA and the PFO. Capillary refill improved, extremities are now warm and well perfused with better pulses, and we could be able to go down with the noradrenaline infusion dose. So, what are other uses of vasopressin inside PICU? In case of catecholamine refractory septic shock, as was mentioned in the previous lecture, if we are struggling to improve the perfusion using both noradrenaline and adrenaline, vasopressin is the vasopressor of choice, and it has a potent vasoconstrictor effect. And unlike the norepinephrine or the epinephrine, it doesn't touch the myocardium, so it avoids the patient the tachycardia and arrhythmia, which are caused by catecholamines. In case of cardiogenic shock refractory to catecholamines, and in cardiogenic shock we are restricted, because going up with adrenaline in case of sick myocardium is going to cause a tachycardic effect, to increase the oxygen consumption of the myocardium and to cause arrhythmias. So vasopressin doesn't touch the myocardium and improve the perfusion without these side effects. And it improves the coronary perfusion as well by going up with the diastolic aortic pressure. Inside the cardiac centers and cardiac ICUs, in post-cardiac surgery, cardiogenic shock, especially after cardiopulmonary bypass, as those patients develop vasoplegic shock and resistant to catecholamine. So it helps to restore the mean arterial pressure and perfusion without stressing the myocardium. And it is used during ECMO for cardiogenic shock as well. And it helps to maintain adequate perfusion and systemic vascular resistance. Thank you, and I hope you found that useful.
Thank you very much, Dr. Rehab. And now we will go for the question session. And there is a lot of questions from colleagues for both session and all the speakers. So let's start for Dr. Ali and Dr. Stephanie. They would like to know about if there is pediatric patient with refractory septic shock and evolving the multi-organ dysfunction in PICU. How would you minimize the risk of tachycardia and organ hypoperfusion?
I'll leave this for Dr. Shu. Do you want to answer, Dr. Shu?
I apologize. I was typing an answer.
So refractory septic shock with multi-organ dysfunction in PICU. They are asking about how to minimize the risk of tachycardia and end organ hyperperfusion secondary to the treatment.
Yeah, this is really tricky, right? So certainly think about in tachycardia, are you intravascularly repleted? And so is some of your tachycardia due to continued inadequate fluid resuscitation? And then really tracking your secondary markers of end organ perfusion. And so there will be a balance of titrate to effect, right? So to a certain point, okay, I'm getting improved SVR, improved mean arterial pressure, and initially I see some decrease in the mind markers of end organ dysfunction. And then beyond a certain dose, I start to see, okay, my lactic acid is worsening. I'm now no longer, I had a robust response in my urine output. And then now as I continue to go higher, my urine output is dropping off. I'm developing digit or limb ischemia, or my lactic acidosis for some reason is now worsened. Then I probably just start to walk it back down to where that sweet spot was. I think one of the other questions that I saw was a question about rate of titration of these vasoactives. So both for norepi and epi, I think about 0.02 mics per kilo per minute as I'm titrating up, depending on how their response is. And then titrating back down, I think about, again, depending where we are, typically 0.01 mics per kilo per minute is how I titrate back down. And I generally do that about every 15 minutes or so to make sure that I'm not going faster than the patient is recovering.
Good, thank you. The second question for Dr. Ali. What are the key difference between using vasopressor and the inotropes in terms of their mechanism of action or receptor or action?
Well, I mean, if you start thinking of it as how does, for example, dopamine fare against norepinephrine is dopamine is just a precursor. So it will eventually act the same way as norepinephrine will act. The problem is dopamine will have more arrhythmogenic effects in pediatric patients, higher mortality rate in pediatric patients when we reach the pure form of norepinephrine. It did not seem, even though the benefit of increased renal perfusion weighs anything against just straightforward using norepinephrine as a start or epinephrine as a start in these patients. And I think we tackled it in the lecture where the alpha receptors and beta receptors were act. So just for the sake of time, I can always type it out, but not this section again. Vasopressin, I think Dr. Ragab really explained it where it just acts in a different pathway completely than the other two, which can overcome the vasoplegic shock. So you can use it as a third line effect, in my opinion.
Very good. Okay. This is for Dr. Rehab. You mentioned about vasopressin and high doses of vasopressin. What is the prolonged effect of using high dose of vasopressor in children?
So the question is about the effect or side effect, sorry?
The long use of high dose of vasopressin in children. If you use it like
We use
one
it
day, high
yes,
dose,
we use
is
it,
there any organ will be affected?
yes, we use it very cautiously, and we monitor the signs, the clinical signs of side effects. It can cause severe ischemia to the digits, and we have reported cases of that. It can in neonate in this very specific situation of persistent pulmonary hypertension. If we started feeding with vasopressin, there is a very high risk of necrotizing enterocolitis. So we are cautious with that as well. And in very high doses, very high doses, it could stress the myocardium, but less than the adrenaline. And it has a severe hyponatremia effect. And this is why we use it until we achieve the effect of it. Then we start weaning as soon as we can.
Very good. Okay, so there is some question about using centrally or peripheral line. The drugs of inotropes can be used peripheral, but you need to look for the preparation
Yes.
of the peripheral.
Yeah,
I'm talking about the inotropes, not about vasopressor. Any comment about this, Doctora, since you talk about it?
so there is a question: can we start vasopressin as a first choice? Actually, the literatures suggest vasopressin as a third choice or second choice, but here inside the United Kingdom and inside the cardiac centers, there are local guidelines that use the vasopressin as a first drug of choice in case of severe PPHN, especially cases who are admitted for ECMO into the cardiac ICUs.
Okay, thank you very much. I think we will end this question session. And actually, as we learn from our speaker, that using inotropes and vasopressor, it is kind of art. It's not just drugs that patient hypotension. Okay, I will start him epinephrine. No, I will start him norepi. We have to know the mechanism behind using this kind of drugs. Why I want to use it? What is the receptor that will help? What is the dose that will shift it from beta to alpha? And what is the kind of patient? Is it septic shock? It is heart failure. So it is an art we need all the time to learn from our patient, from our intervention. Both those tropes and vasopressor use in critical care patient, and we choose it upon the condition of the patient. There is a many supportive intervention that help when you are using the inotropes, like ECMO, like some drugs that mentioned by our colleagues, like using hydrocortisone, like adjustive drug. And in behalf, because of that time, in behalf of the near 50 attendees, and I would like to thank you, all of you, all the time. You stay around 50, 500 and 450 of attendees. I would like to thank the organizer in the committee in the WICCEM, and also our speakers, Dr. Stephanie, Dr. Ali, and Dr. Rehab. And by this time, I would like to close and end this webinar. Thank you very much.
Thank you, Dr. Turkey, and thank you for all the speaker. Just housekeeping stuff. Our next webinar would be on Wednesday, October 8th. It will be focusing on nutrition and critical ill children in ICU. Second is by tomorrow, you should receive, all of you, the link for the recorded webinar. The third announcement is by next week, all of you should receive attendance certificate. And with that, I really appreciate your interest in learning, and hopefully this information will help you to improve your patient care and patient outcome. Thank you.